The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Rogers.
Yes, here.
Representatives Whitsett. Carter.
Here.
Hadsma. Neely.
Here.
Glanville.
Here.
Kafia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingens.
Here.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you, and let the record reflect Representative Hadsma has joined us. I would like to recognize youth and government members in the audience from Pontiac. Welcome to Health Policy Committee. Representative Reingens moves to approve the minutes from our meeting on March 5th, sorry. This is what happens when you write your own script. I apologize. From our meeting on April 18, seeing no objection, the minutes are approved. Prior to testimony and votes, if you wish to speak or express your position on legislation before us today, please submit a card to the clerk. Sergeants in the room will be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, you are also welcome to submit written comments to be submitted to the bill record. First, we will take votes on the two bill package we heard testimony on April 18th, Senate Bill 449 and 450 regarding complex rehab technology. Then we will hear testimony on House Bill 4291, Representative Braybeck's bill regarding sudden cardiac arrest education. Finally, we will hear testimony on SB 482, Senator McDonald-Rivet's bill on regulations regarding sharps containers. First up, we will take a vote on SB 449 and 450, sponsored by Senators Daly and Irwin, to regulate how customized medical equipment is provided to residents. There are subs which were distributed for discussion purposes last week to our committee and have been finalized. We have no additional cards to read in. Minority Vice Chair Vanderwall moves to adopt H1 substitute to SB 449. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Miller.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson. Madam Chair, you have 17 yeas, 0 nays, and 0 pass. The substitute is adopted.
Minority Vice Chair Vanderwall moves to report SB 449 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson. Madam Chair, you have 17 yeas, 0 nays, and 0 pass. The motion prevails.
Representative Miller moves to adopt H1 substitute to SB 450. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson. Madam Chair, you have 17 yeas, 0 nays, and 0 pass. The substitute is adopted.
We're so agreeable on King's Day today. Thank you, ladies and gentlemen. Representative Miller moves to report SB 450 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson. Madam Chair, you have 17 yeas, 0 nays, and 0 pass. The motion prevails.
Next, we will have testimony from Representative Braybeck on House Bill 4291, legislation regarding education and practice around student athletes and sudden cardiac arrest. There is a draft substitute which the presenters will be speaking to today and should be before you. To speak to the bill, we have the sponsor, Rep. Braybeck, Mark Ewell, Executive Director of Michigan High School Athletic Association, John Seco, the third President of Michigan Athletic Trainers Society, and Dr. Michael Roebuck, Chief Medical Information Officer and Assistant Director of Emergency Medicine at the University of Michigan Medical School. Go Blue. Chair Braybeck, the floor is yours.
Thank you, Chair. I really appreciate it. Good morning, colleagues. Really happy to be here with all of you and excited to talk about this bill and to also hear from our other experts, both in the sports field and medical. I want you to think about Jalen Mitchell, a high school student from Ypsilanti, the town right next to Ann Arbor, where I get to represent, who died suddenly at basketball tryouts in front of his twin. Cartier Woods, a student from Detroit who collapsed during his basketball game and died later in the hospital. Alexander Bowerson from Memphis, Michigan, collapsed during wrestling practice. Thankfully, he lived and hopes to someday be a cardiologist. All of these students had incidents of sudden cardiac arrest disorder, or sudden cardiac arrest. So what is it? It's a life-threatening emergency that happens from an abrupt and unexpected loss of heart functioning, leading to a loss of consciousness and collapse. It can be fatal, as evidenced by both Jalen and Cartier's lives. But it needs to be treated within minutes. But we can hope to prevent some of this, particularly with our young student athletes. And we need proactive measures to help prevent some of these tragedies. Here's a little bit more information about the problem. According to the American Academy of Pediatrics, SCA, sudden cardiac arrest, takes thousands of students' lives every year and is the #1 cause of death in student athletes. In fact, some experts believe that sudden cardiac arrest is responsible for 1 death in a high school student every 3 days. In contrast, the CDC, our Center for Disease Control, reports 1.5 deaths per year due to sport concussion. And I want you to remember those stats as we continue talking today. The American Heart Association released a featured science abstract in 2023, capturing the results of a 20-year study. And again, they found that sudden cardiac arrest was the most common cause of death for NCAA athletes. In fact, they found high incidence of SCA in black and white male basketball players. Additionally, male athletes were 4 times more likely to die from sudden cardiac arrest as female athletes. And finally, black athletes were about 3 times as likely to die from sudden cardiac arrest as white athletes. According to the American Board of Family Medicine, nearly three quarters of students who suffered from SCA were reported by their parents to have had at least 1 cardiovascular symptom before the event. They just didn't recognize it as being life-threatening. I have one more piece of information I'd like to share with you, and that's from Dr. Ashley Simmons. She's a cardiologist and medical director of the Women's Heart Health Program at the University of Kansas Health System, and she said, we need to know the warning signs and be prepared. And that's what this bill hopes to do. Educate student athletes, their parents, and coaches about some of the potential warning signs and symptoms when they are present. Education and the subsequent medical response to those warning signs can save young Michiganders' lives. So here's what the bill does. As I mentioned, first and foremost, this bill seeks to educate our student athletes, their parents, and coaches about sudden cardiac arrest. And it requires student athletes and their parents to review and sign an information sheet on sudden cardiac arrest. And it requires high school athletic coaches to undergo an annual online training. And that can be provided by the department. Many versions are already out there. The most used course right now is from the National Federation of State High School Associations. So we have this training already out there. This bill calls for the immediate removal of athletes showing SCA symptoms until cleared by a medical professional. And remember, all athletes, when they participate in high school athletics, have to have a release to be able to play. They have to have a medical form signed by a practitioner before they can play every year. We bring our kids every year to do that. And so what's unique about this bill is that this bill hopes to do some education work so that we can prevent sudden cardiac arrest. AEDs, those devices are a very important piece of this equation, but they are needed once the cardiac arrest already happens. And we recently passed bills, Rep. Fitzgerald and Rep. T. Carter's bills around this, and those bills are a lot about training and placement in schools for our AEDs, and I believe that these three bills work in conjunction with one another. We have the education, and then the training, and the ability to have the equipment needed to be able to save lives. This is really important. Again, educating parents and the student athletes and the coaches are really important. And this bill includes the warning signs that are listed by the National Institute of Health. And there are several of them. Sometimes it's important to know, and I just want to state, and this bill does have this in there, that sometimes there can be no signs. But as you heard, about 3/4 of parents do say that there was at least one symptom present. And so that's why it's really important to know this. So we want to allow parents and coaches to be better informed so that they can make more educated and safer decisions about the well-being of their children and their student athlete. We know that early detection can make a difference between life and death for our student athletes. And I want you to go back to those stats that I said about concussion. 1.5 deaths. But then for sudden cardiac arrest, some experts say it can be 1 every 3 days. We do this for concussion already in this state. As parents of student athletes and our student athletes, we have to read almost every season, certainly every year, signs and symptoms of concussion. Our kids know that. We know that as parents, and that has made a difference. That is now passed in all 50 states. We are seeking to do the same thing that we're doing for concussion already, but for sudden cardiac arrest. The education needed to be able to recognize when a student may be in trouble, and then getting a release from a physician, a primary care physician, so that that student athlete can return safely to play. So this type of law, like I said, the concussion law is in all 50 states already. This type of law is in 18 states. The first one was Pennsylvania. And I believe that sudden cardiac arrest education can help with saving the lives of our young Michiganders. And I hope you'll join me in supporting this life-saving education for our student athletes.
Thank you. Next up, we have Executive Director of Michigan High School Athletic Association, John Seco III, President of Michigan Athletic Trainer Society, to speak in support of the bill, as well as Mark Ewell, sorry. It doesn't really matter. Whoever would like to go first.
I'm here. My name is John Seco, and I'm the president of the Michigan Athletic Trainer Society. Our goal as a society is to promote the profession of athletic training in the state of Michigan, as well as advocate for improved health care among our various patient populations, one of which is youth athletics. Today, I stand before you to emphasize the critical need for the development of educational materials and training programs concerning sudden cardiac arrest in athletes, particularly focusing on children and youth athletes. Health is the cornerstone of any athletic endeavor. Our young athletes represent the future of sport and overall the future of Michigan. As a representative for athletic trainers here in Michigan, I feel it is our duty to safeguard their well-being in any way possible, the easiest of which is through education. Sudden cardiac arrest is rare but potentially fatal, especially among youth athletes due to their intense physical exertion and, sadly, the unawareness of underlying conditions or symptoms or level of health literacy. By establishing standards of educational materials and programs aimed at educating coaches, parents, and athletes themselves through this bill, we can equip them with the knowledge and tools necessary to recognize warning signs, respond swiftly, and prevent tragic outcomes. Such initiatives as those outlined in this bill enhance the overall culture of safe athletic participation and promote lifelong health and well-being. When athletes feel supported and safe, they can focus on achieving their full potential. Parents gain a peace of mind knowing that their children are participating in sports under informed supervision. Coaches and administrators become better equipped to promote healthy balance between competition and well-being, and healthcare providers can direct prompt, adequate, and equitable care. Ultimately, prioritizing health and health literacy fosters a more sustainable and fulfilling athletic environment. On behalf of the Michigan Athletic Trainers Society, I'm happy to support this and any bill that prioritizes health and safety, ensuring that youth athletes and their families are provided education and information empowering them to participate in sports safely and to allow them the ability to thrive in their communities on and off the field. Thank you.
Thank you. Welcome, Mark.
Good morning. I'll be short and sweet. The instances that Representative Braybeck noted thankfully continue to shrink each year in our state. However, one is too many. I am pleased to report that I can sit here and at the end of, I've been on staff now, I'm in my 21st year, that in each year on staff, I can sit at the end of the year and talk about the number of saves that we have had in the school versus those that we've lost. But again, any loss is something that is one too many. Currently, we require all of our coaches to be CPR certified. We require for all of our tournament events that an AED be present. The big focus that we have moving in the next school year is that not only do schools have emergency action plans on file, but they are practiced and rehearsed. What we found is the sudden cardiac incidents that that really happen in our space the most number of times are usually from middle-aged folks like myself who are a little too heavy, or in many cases it's grandparents at games that have that sudden cardiac situation. Education is important from a practical standpoint. If this bill would become law, we would take this kind of education and simply roll it into what we already require for concussion. So in terms of would this be an undue burden on schools or on parents, well, essentially they would get that medical information each year in a package. It would be concussion, it would be sudden cardiac, and we just feel like we could cover more bases that way but still do it very, very efficiently. So anything that we can do, and by the way, and the last thing I'll share is the concussion pendulum has swung the other way, and it's not because we've stopped playing contact sports. What we've done is we've put the issue of the signs and symptoms of concussions on the radar of moms and dads across our state and frankly across our country. And if we can take that same education and put it on the radar of folks when it comes to sudden cardiac, we just think, again, one is too many and maybe we can get at that small handful that we have. So the MHSAA is supportive of this. We don't believe that this would be an undue burden on our schools. It would just be an additional step of education as we try and keep everybody involved as safe as possible. Thank you.
Thank you. We've got one more testimony on Zoom, and then we're going to do questions. So next, testifying via Zoom, we have Dr. Michael Roebuck, Chief Medical Information Officer and Assistant Director of Emergency Medicine at the University of Michigan Medical School.
Hi, good morning, everybody.
Good morning.
I am Mike Roebuck. I'm an emergency physician. I've been doing this about 25 years. I work for the University of Michigan, but I do all my work at Hurley Hospital in Flint. We started this presentation with a discussion of a young IPSI athlete that died in 2021, I think. My son played on Skyline's basketball team in Ann Arbor, and that same year we played IPSI in a JV game. One of their players had chest pain during the game, and the coach brought him out and sat him down on the bench. I was a little shocked to see later in the game, the same player re-entered the game and continued to play while kind of holding his chest and complaining of chest pain. After the game, we evaluated him on the side and we sent him to Mott Children's Hospital for evaluation. And ultimately, as far as I know, he was fine and discharged from there. I think, though, the way that particular case was handled speaks to the variable approaches to this. And I'm hoping the bill that's on discussion today would create some standardized approaches to a young high school athlete that has chest pain during the game but is allowed to continue. I'm sure you've all heard of the screening efforts that go on, the teen heart screens that have been adopted by a lot of places, and those have had variable success. The science of screening is ever evolving, and I am confident that in the future, things like that will have some success. The best treatment we know now is the AED, and I see that you guys are working hard to get AEDs present in the gymnasiums for quick treatment. But I do think that's treating one arm of this, right? That's treating the kid after the arrest. And I see this bill as completing that loop a bit, standardizing the awareness, the education, and the handling of these young high school athletes. Because as was just said, even one of these incidents per year is far too many. So for all these reasons, I support this bill.
Thank you very much. We do have some questions. I have Representative Roth, followed by Filler and Glanville. Representative Roth.
Thank you, Madam Chair. Just trying to wrap my head out a little bit around it. I appreciate what you're trying to do. I know a large heart is a major issue in some of these athletes that do have cardiac arrest, and having that diagnosed early is great. I'm trying to wrap around how we do it here, and if we don't put more pressure on the medical doctors to screen for that, might be the better way to go. Now, I'm trying to wrap my head around all of it, but I just think the medical community screening for that enlarged heart problem that's out there makes a lot of sense. So I don't. Are we screening for that as we do as part of the physical? And I went through 6 years of physicals as a former athlete too. Mark, I share your issues, but just trying to wrap my head around it and why we don't maybe push towards the medical community a little bit more for the screening process, and if we're doing that.
So does someone want to answer the question of what's already done for sports screenings and how that does or does not address what we're talking about today? Rep. Braybuck.
Actually, this is an issue that Dr. Roebuck and I were talking about yesterday. It depends on the doctor. You know, our kids, I bring our children every year for their sports physical. They've never had an EKG done during those. I had to bring them, our oldest one, when he was eligible for one of the screenings at now Corewell Health. You know, I brought him to that to make sure that his heart was okay. That was separate from our daughter. I have to do it yet because she wasn't old enough at that point. But that was something that I, as a parent, I knew about the program, and then I went in and proactively did that for our young student athletes. But I know that there are other pediatricians who do regularly screen, and so my understanding is that, and my experience is that it depends on the provider.
And Dr. Roebuck, did you want to chime in as well?
Yeah, I would add that the Academy of Pediatrics doesn't expect an EKG to be done for every sports physical unless the patient's at risk. And so the risk would be defined by family history, shortness of breath, chest pain on exertion, syncope on exertion, things like that. If things turn up during their physical, such as that, they would do the 12 lead. But often as these athletes enter high school, they've not competed rigorously or competed to that extent, right? Further, these pediatric guidelines have been in place for quite some time, and these sudden cardiac arrests are still happening. So as I alluded to a bit earlier, the science of screening for this is still evolving. We, in over time, it will get better, and we will get better at this. But for now, despite the measures that are in place, these events still happen.
Thank you. Representative Filler.
So I have
Sorry,
two.
Chair.
Oh, sorry.
I'm so sorry, Chair.
Sure.
John wanted to
Sure,
say something.
go ahead.
All right?
Thank you. I think you only know what you know, and providing youth athletes, parents, a list of signs and symptoms surrounding sudden cardiac arrest allows them to formulate questions to bring to their provider, bring to their urgent care, bring to their primary care physician, so that they can start the conversation with that provider to maybe get further testing or have that conversation that it doesn't need further testing. But like I said, you only know what you know. So if you're provided with more education, you can formulate more questions to have a conversation with your healthcare provider.
Thank you. Representative Filler.
I have two quick questions, if the chair allows. Section 9158, let's see. Subsection 3, a coach or any other adult employed by, volunteering, or otherwise acting on behalf of an entity shall immediately remove from physical participation in an athletic activity a youth athlete who is suspected of having symptoms or a cardiac arrest. I guess I have some liability questions here, where I think this would open up volunteers and coaches to be sued. Right now, I assume that they do their best. They review the situation and that they do their best. Well, when we put it in statute, all of a sudden we've given anybody who feels there may have been an inappropriate action an ability to file a civil suit pretty quickly. And so I guess that's my first concern that I want to bring up.
Yeah, thank you for that. If the language needs to be tweaked, that's something that we can work on, but it's the hope is to be able to be responsive to the knowledge that something is happening. You know, like Dr. Robick was talking about, I was at that game too with this young student athlete, on the same team who lost a teammate earlier, just months before, that there are reasonable responses to an event that happened and then to get care.
A quick follow-up, and actually an entirely different question, but this is not just high school sports, right? This is all activities in the state of Michigan this bill applies to?
So it focuses on high school sports. We did put in there other activities because there are other club,
Like rec league,
club,
YMCA.
right? And
So they would all need to go through the
That's
processes
part
of
of
this
this
bill.
too. Yeah, and we have to do that right now. Again, as parents of athletes for those kinds of activities, we already have to do that for concussion.
Okay.
That's already in place right now.
Thank you, Chair.
Thank you. Representative Glanville, and then Representative Carter.
Good morning. Thank you all for being here today. I appreciate I really appreciate this bill as a former coach of youth athletes. Anything we can do to protect our kiddos, of course, is imperative. So, but I do echo my colleagues' concerns about liability. That was one of my primary questions, particularly when we consider the psychology of sports and how many people play through injury. Kids might not even tell somebody that they're having symptoms, that kind of thing. So I would like a little bit of clarification around that piece. And then also knowing that we have youth themselves who act as umpires and referees in some of our recreational league sports and things like that we're putting a burden on even a 16-year-old to maybe make that decision for another kid. So I just want to be mindful of kind of who all this is going to impact and what that means for their role and how we protect them and things like that. The other thing I want to mention, I appreciate, again, my colleagues' comments about one particular condition. I know there are many conditions that could be a factor in something like this, but I also want to highlight how this kind of treatment can also uncover other conditions. Myself, I went through a period where I had severe chest pains. Perfect athlete example. It took me 3 days to get to the hospital and say, I'm still having chest pains, which turned out to be asthma. So, so there are other conditions that can be uncovered and treated through having this awareness. So I appreciate all that. My final question is around the primary care physician piece, and I wonder if we need a definition or if I just need a little more education. What about our kids who maybe don't have a primary care provider, or who don't have health insurance or something along those lines? How are they getting the follow-up care necessary to be able to continue participating?
Great question, and it's one that the language is very intentional. Because we started off with different language for that. But because every student athlete has to get that sports physical, there's engagement with a primary care physician. And in talking with folks in the medical profession, that language encompasses folks at urgent cares, pediatricians. That is the language that gets used. And maybe we do need to put a definition, but that is the parlance that gets used to be able to indicate all of those. Anyone who is doing that kind of sports physical, that is the language that includes those different where we can get the care for those students.
Maybe I'm misremembering or things have changed, but don't some schools have like a physician come in and do those sports physicals, like, kids just come in and get them done like on
You're right, yeah,
Tuesday.
that
And so that may not be there. Like, I don't know how that information gets translated back to a primary care provider or something like that.
There were not many good things that COVID brought about. Actually, one thing that COVID did bring about was these mass sports physical nights. Prior to COVID, a school would bring in a handful of docs. They would do these mass physicals. And really, since COVID, those have now gone away. And the benefit from that has been kids going to a provider's office, whether it was their direct provider or at least an urgent care, to where not only are they doing the physical assessment, but today they're also asking questions about, are you ever depressed? Do you ever feel anxiety? Which those were never happening in the gymnasium type physical. So there aren't many on my list, but that is one of a positive kind of sea change since COVID.
Okay, is that something we need to talk about in this bill, if there are still schools doing the mass physical?
It's something I'm certainly willing to take a look at and try and understand the scope and see if that's necessary.
Okay, thank you.
Sure.
All right, next up we have Rep. Brenda Carter.
Thank you, Madam Chair. First of all, I want to applaud this legislation. As a former school board member for the city of Pontiac, and then the president of the Michigan Association of School Boards, we were elated when the concussion laws were put in place to educate. Okay, this is a huge opportunity to begin to educate our youth and their parents on the signs of cardiac arrest. And then most importantly, have something in place that could mitigate that. So I just want to say, as a school board member, and you have your youth all of a sudden going through these symptoms, and they don't know what it is because we haven't explained what they're going through. So if we can take that initiative, if this legislation does that, particularly Rep. Brayback in under-resourced communities that are impoverished, they really don't have the things they need to treat their young people. So if we can just accelerate this, I know it would be appreciated in all the almost 1,000 school districts in the state of Michigan. Thank you.
Thank you, Representative Carter. I would say that, in reaching out to stakeholders, the School Board Association was one, and we worked on particular things, particularly the language around providers, and that particular issue of kiddos having access to be able to get back into sport. And so I really appreciate the engagement, with them around that. So thank you.
Representative Hadsma.
Thank you. This is a question for Dr. Roebuck and follows on the response of Representative Brayback to the question by Representative Roth and focuses on the subjectivity of these screening examiners. How, as you put it, does this standardized approach kind of help us, given the fact that there is often subjectivity of examiners who are physicians, nurse practitioners, physician's assistants?
So I'll start by saying that the subjectivity in screening will always be there. The screening is very imperfect, right? An EKG finding doesn't necessarily guarantee you're gonna prevent a cardiac arrest. An ultrasound finding doesn't necessarily mean you're gonna prevent a cardiac arrest, but I think that awareness of the symptoms that bring concern could. I think if an athlete is competing and gets chest pain or gets short of breath or feels as though they're going to pass out, that's going to get them in front of a provider who's going to ask more questions and do the right things and maybe lead down the right road and prevent an arrest.
Thank you.
Any other questions? Seeing none, we do have a couple of cards to read in. So supporting the bill is Michigan Nurses Association. And that is it. Thank you so much for your testimony today.
Thank you, Chair. Thank you, colleagues.
Moving on to the next bill, we have Senate Bill 482. And to speak to it, we have Liz Tremblay from Senator McDonald Rivet's office, followed by Cindy from Eagle, and Andrew Daniels on Zoom, President and CEO of Hills and Dales Hospital. Welcome to Health Policy, and begin whenever you're ready.
Yes, thank you, Chair Rogers and members of the Health Policy Committee. I'm here today, I'm Liz, on behalf of Senator McDonald-Rivet to speak to you all about Senate Bill 482, which pertains to the disposal of sharps containers. So Michigan is a little bit of an outlier in our requirements for disposing of these containers. Current practice, national standard, observed by the FDA and by OSHA, is to dispose of these when they reach 3/4 full. But in Michigan, we require them to be disposed of every 90 days. So in very busy areas, and especially urban areas, they are usually full at these 90 days, but in rural communities and in extraordinary cases like the COVID-19 pandemic, a lot of these containers are near empty or completely empty, having to be disposed of, especially within 90 days. So what this bill does just puts us into the national standard of disposing these when they reach 3/4 full instead of the current practice of 90 days, hopefully reducing some unnecessary costs for a lot of medical facilities and reducing unnecessary waste. Thank you.
Thank you very much. Do we have questions at this point? We will have another opportunity in a second with additional testimony. Okay. Seeing no one else, next up we have Sydney Hart and Rhonda Oyer from Eagle.
Thank you.
Good morning, Chair Rogers, members of the committee. Thank you for the opportunity to testify in support of Senate Bill 482 with suggested changes. I'm Sydney Hart, Legislative Liaison for the Department of Environment, Great Lakes, and Energy. And here with me today, I have Rhonda Oyer, our Solid Waste Section Manager of our Material Management Unit. So in 2017, the Medical Waste Stakeholder Advisory Group reviewed current regulations and was supportive of legislative amendments to the statute. MWSAG was representative of several professional healthcare organizations, including the Michigan Health and Hospital Association, Michigan Society for Infection Control, the Michigan Dental Association, the Funeral Home Directors Association, Veterinary Association, waste vendors, and knowledgeable regulatory staff like Rhonda here. Of the recommendations was an extension of sharp storage to 1 year as part of comprehensive amendments to the Medical Waste Regulatory Act. Since the MWSAG's final meeting and review of the draft proposed amendments in the summer of 2019, incidents have occurred involving improper management of medical waste. And there have been multiple requests for regulatory relief from the 90-day sharp storage requirement due to increased demand for sharp containers as part of the COVID vaccine efforts and supply chain issues that have made obtaining sharp storage containers difficult for an extended period of time. We recognize and welcome the increased interest in modernizing the Medical Waste Regulatory Act and rules to ensure overall protection of public health. Senate Bill 42 as written would allow regulated medical waste producers like hospitals, dental facilities, physician practices to store medical waste for more than 90 days if the sharps container is not filled to more than 3/4 capacity. However, the definition of medical waste goes beyond sharps to include things like bodily fluids and blood products. Some of this medical waste may be subject to putrefaction and produce odors, and we wouldn't want them to be stored in a sharps container. We would suggest that the language be changed to clarify sharps rather than medical waste be stored in a sharps container up to 3/4 capacity or not more than 1 year. And with that, I want to thank the committee for taking the time to hear our testimony and for the sponsor for her willingness to work with us on the language. Rhonda and I would be happy to take any questions the committee may have.
Thank you. And then we have one more person testifying in Zoom. Rep. Vanderwall, do you have a question for Eagle?
I do.
Okay, go ahead.
All right. Thank you, Madam Chair, and thank you for being here. I guess just kind of listening to the testimony, I agree with you on the terminology of medical waste because of course, of that situation is there. But if we're addressing the situation of 3/4 full, why would we put any date stipulation on a sharps container if there's I mean, we've all seen them inside certain facilities, and they're always quite empty. Why all of a sudden do we want to put a mandatory 1 year if there's only a few in there? I think we go to 3/4 once we hit that point in time. Can you give me an explanation of why it has to be even a time frame put on there if it's just 3/4 of the way full?
Representative, I believe the reason for that was to prevent people from just storing it forever. You know, because there are some facilities that maybe they would not get to the 3/4 full for several years. And we would not want those containers to be available to anybody who might want to misuse the materials in there. We have had cases where people have stored the Sharps container in a area that was not very secure, and that people that have addictions to certain drugs will try to go through those containers to obtain that medication, and we would not want those to be available for that sort of activity. So I think we want to just ensure that they are eventually getting taken care of, and a year seems like a reasonable time frame.
Well, and I appreciate the thought process. I guess, you know, I want to challenge back a little bit, and I'd love to work with you on this. But, I mean, if somebody's going to get into a Sharps container, they know where they're at, and they're going to do that in any given period of time. If it's 1 week, 1 month, 2 years, 5 years. But love to work with you and just maybe potentially looking at some type of change or coming to an agreement on a time frame. But appreciate you being here. And again, thank you, Madam Chair, for allowing me to ask a question.
Thank you. Following up, my question is, does any other state have a 1 year? Are you aware of any other state that has a 1 year stipulation, or where did the 1 year come from?
I'm not aware of anybody that has a 1 year, but I could do some research on that and we could get back to you.
That would be great. Thank you. Yeah. I think we have a question from Representative Thompson, and then we're going to go to the last testifier on Zoom. Representative Thompson?
Thank you, Madam Chair. Anyone is available to answer this question, but I agree with my colleague. Being a nurse and utilizing Sharps containers and understanding that it's not just for Sharps, but it is also for the medical waste. And you mentioned drug addicts that want to go in the Sharps containers to get used fentanyl patches. There's so much that's involved in that. My question was, absolutely, the longer that they're let to be sit there, the longer you're at risk for a sharp injury. My concern is that, and anyone that wants to address that is open to. And then also, I was concerned also with the odor. And then one third question, if anyone could address that, is anyone where the bill sponsor reached out to the medical waste providers who they've reached out to me, and they were opposed to it because they felt that it would take away from their business as small business owners if they were allowed to sit there for longer periods of time. It would have a great impact on small businesses that do pick up of these containers.
Do you want to address the first part, and then the bill sponsor can address the last part?
Sure, and Ronna can add anything, but I think we agree, right, there's a concern about accessibility of the Sharps, and there's also, as mentioned in the testimony, putrefaction and odor concerns that we have with the Sharps being stored for a long period of time. I wouldn't be able to speak to conversations with the sponsor's office on the medical waste regulatory aspect of that, but happy to follow up. We have continued conversations scheduled with the sponsor's office, so hopefully we'll be able to report back to the committee.
Thank you. Liz, did you want to address the last part of the question, conversations that have been had with the medical waste providers?
Yes, so our goal here is just kind of to reduce cost and unnecessary waste. Michigan, again, is an outlier in this practice and is not observed as a national standard.
Thank you. All right, last on Zoom, we've got Andrew Daniels, President and CEO of Hills and Dales Hospital and co-CEO of Aspire Rural Health Systems. Welcome to Health Policy, and thank you for your patience.
Hey, good morning, Chair Rogers and members of the committee, and thank you for the opportunity to testify today on behalf of Michigan's community hospitals in support of Senate Bill 482. My name is Andy Daniels, and I am the President and CEO of Hills and Dales Hospital, as well as the co-CEO of the recently formed Aspire Rural Health System, which includes 3 critical access hospitals: Deckerville, Hills and Dales, and Marlette. As you know, rural healthcare is vitally important to the health and the well-being in our state, and you can take it from me, it's rough out here at times. And one of the consistent challenges we face, particularly in rural settings, is being able to cost effectively and efficiently serve our communities. When we put these 3 hospitals together, our goal is to keep affordable, high-quality healthcare in the Thumb region, and part of doing that is maintaining those services, is to work and look at what's working well and what isn't, and to recommend ways to reduce burdensome inefficiencies. It's my belief that Senate Bill 482, sponsored by Senator Kristen McDonald-Rivet, does just that. It eliminates inefficiencies in favor of cost savings and reductions of medical waste. Currently, as you know, facilities must dispose their sharps containers every 90 days, and there's a little nuance listening to some of the questions. We're not talking about storing them forever. Once we take them off a wall, and we have a timeline that we destroy them anyway. So, and that is 90 days. So if you're following the rules, you're not holding on to that stuff once it's full. The way Michigan's current rule starts is the clock starts the day I put it on the wall. And so I have to take it off the wall, whether it's full or not, used or not, empty or not, it's done. So I don't think anyone's, I heard some of the comments and questions, but I just wanted to try to frame that in context for the committee. The 90-day timeline was probably well-intentioned, but in practice, especially in rural health systems, all it's really doing is contributing to medical waste and really increased costs because of an arbitrary timeline. As you've heard, 90 days, we may not use a sharps container to its capacity and cycling through the container for 3/4 full, and it's just wasteful. It contributes to unnecessary cost when containers must be sealed and destroyed before they're filled to the FDA's 3/4 mark. And we believe that SB 42 will save us money, will reduce weight, and aligns Michigan with the requirements set forth by all the other federal safety and regulatory agencies. Our accreditation bodies, all of them, OSHA, it's bloodborne pathogen standards, it aligns it across the country. And as has been said here, we are really an outlier. So I'd like to thank you for your consideration to this legislation to streamline how Michigan regulates just one small but important part of our day-to-day operations of healthcare facilities. And I look forward to your support on SB 482. And I'm happy to answer any questions I might.
Thank you. Another question from Minority Vice Chair Vanderwall.
Thank you, Madam Chair. Thank you for being here. Just a kind of a quick follow-up, but, listening to your testimony, and I understand completely where you're coming from. Right now in the 90 days, when that metal or that waste container comes off the wall that we've all seen is established in there, do you guys weigh those, or are they just picked up and they're immediately brought in and destroyed?
So we actually store them in a biohazard area within the hospital, and then they are picked up and then destroyed. So we would change them out as they get 3/4 full. If the bill changes, we store them no longer than 90 days, which is part of kind of our accreditation standards, and then they would be out the door.
Can you tell me at 90-day rate that's being changed now? Can you give me an estimate? Is there...
I would say it's 50%. So
50,
last
okay.
year, just my little organization, we spent $44,574.08 swapping out sharps containers, of which 50% of them were probably, well, I would tell you none of them were 100% full, but 50% of them by sure were just dated and now expired.
All right. Thank you. I appreciate the information.
Thank you. My last comment will be from personal experience. As a physical therapist in an outpatient setting, one of the functions, little known functions that we can perform in our scope of practice is iontophoresis. And so we draw up the dexamethasone in a syringe and put it on a iontophoresis patch that we then put the patch on the patient. And so again, the frequency ebbs and flows with how often we do this. And we often in physical therapy clinics in small settings, whether it be urban or rural, will go months and months. And again, it's a large expense to our rehab settings if we have to throw these out what I would say prematurely without them being even half full sometimes. So I am sympathetic to this issue. Supporting the bill, we have Michigan Health and Hospital Associations as well as the Michigan Podiatric Medical Association. Thank you, everyone, for joining us today. If you have additional suggestions for the bills we heard testimony on, please share with the bill sponsors in my office. Representative Hosmo moves to excuse absent members. Without objection, the motion prevails by unanimous consent. There being no further business before the committee will stand adjourned.